Here. All right. Well, I guess I could have confirmed that you guys are all you're seeing the slides okay, but I'm assuming you are. So welcome to this month's how-to webinar series from Synapse Care Solutions. My name is Kathy Randall, and I am excited to present to you on this presentation on creating your aEEG program. And just gonna mute my phone before it makes any other noises. And anyway, so let's get started. Just a really special thank you to our sponsor of this particular webinar. It's Natus Medical and the Division of Newborn Care. And as just full disclosures, Natus provided funding for the production of the webinar, but they didn't have any choice in the speaker, which was me. And they didn't get to participate in the creation of the content. And just as disclosure, I'm the president and owner of Synapse Care Solutions, and we're an education and consulting company for NICUs. So the objectives that I want to make sure that I go through today are really just the aspects of setting up your aEEG program. So at the end, I hope you're able to list at least a few of the aspects to consider specifically about aEEG use in your unit. Then maybe listing some roles that nurses can assume. And of course, the majority of people who watch these webinars are nurses, but certainly I've included other disciplines as well. And then considering who will review your aEEG tracings in your unit and how often. And so I think this interplay is a really important discussion, and I'm happy to field any questions about that as well. So let's just dive right in. So I do have a couple polls throughout, and we may or may not skip them depending. But anyways, I think we're already starting with that. So thanks already for our participant for putting in their little pin drop. And so far on the webinar today, we have just America is represented. But usually on these webinars, we have people really from all over. And I think that that's kind of the fun part about this trend of neuro NICUs is it's really an international trend. And for myself personally, I've been to Thailand, into the Middle East, and I'm actually returning to the Middle East, as well as Brazil, helping to set up neuro NICUs. And so, you know, and there are many, of course, in the US that I've assisted in, but I think this international trend of neuro NICU is really fun to watch. So just so that I can be sure to cover things that are relevant to you, if there's any specific questions, I always want to make sure that I start with kind of that end in mind of what's the thing that you want to learn. And if you want to go ahead and either type it in the chat or respond via the poll, you know, I just want to make sure that I answer your questions too. So again, you can chat them in, or I'll wait a second and see if any responses come in. So we'll, all right. So you're open, this is an open book today. So I think it's important to realize in the NICU especially, anytime we start something new, we really do have to realize it's going to take a village. And this village can be small, little village of a few people, but it typically tends to be more successful if we involve more of our village than less of our village. So I want to start first with how to get started and really thinking about the multiple of roles and kind of decision-making points that need to happen as you bring in your aEEG into the unit, or any really brain monitoring or new technology. So first thing is you need to kind of think about the equipment that you want, develop protocols, so protocols for use and protocols for, you know, who's going to do what, dividing up the roles, which we'll talk a lot about. The sensor application and maintenance, that's a huge piece of bedside brain monitoring. So it's important that you decide who will do these things and what their responsibilities will be. A very important piece is the ongoing review and interpretation of the data, and then of course documentation. So it's important to go ahead and gather up your team. And this isn't, I just thought this was a funny picture, but I mean, our teams, they are diverse. Our teams, it gets a little muddy sometimes, but it is important to really think about your hospital and the key players in your unit. So gathering your team from neurology, from your EEG and diagnostics labs, neonatology, all your bedside providers, potentially rehab, you know, RTs, your advanced practice nurses, administration, very important. Neuro NICUs and aEEG programs are expensive. Your IT department for storage and archiving, and even your research team, and kind of deciding, what you're going to do with all of that as well. So just going to make sure. Okay, yeah, I did. Hi, Janet. Welcome. Okay, so I want you to think a little bit about bringing this new technology and starting this program. So whether it's your full Neuro NICU program or just aEEG alone, it's important to kind of remember this innovation life cycle. And so we start out with those champions in our units. Then we have our, those are the ones that we want to really cling to because they make our lives so much easier. And then we have to kind of move into that kind of middle majority, the sheep, after everybody, all that hard work, they weren't really that excited, but they're willing to go along with the group. And then of course there are the skeptics, and then there's the laggards who finally, get on with the idea. And so I think when we think about our NICU, we need to really think about these champions, the majority, and the laggards. And if you have a big staff or a small staff, I wanted you to kind of have an idea of who or how many people you need to get on your team. So if you're in a small unit of maybe 30 staff, well, then that means you need about 5 to be your champions. That's that 15%. If you're in a unit that's bigger with 100 or 200, then you really are looking for those 10 to 30 people that are really going to be helpers. And then realizing that there's those other 30 people out there who are going to maybe be blockers, or who are going to just, not be on board with your idea of this new technology. And so again, as kind of the team leader and champion, I think it's always important to remember that. So again, we have a little quick poll that you can use if you would like. But I thought it's important to kind of think about yourself, and maybe where are you in this process of adoption and innovator. My guess is that you're probably the innovators if you're here on this call. All right, so let's just do a quick backtrack and just make sure we're all speaking the same language, and talk a little bit about what aEEG, or amplitude integrated EEG, is and what it isn't. And so basically for the bedside brain monitor using aEEG, it's really that complementary tool. We use it in conjunction with other assessment tools, and it's really not meant to replace other things, but it's really meant to augment what we see either in real time with our physical exam, but also some of the individual discrete tests that we do. So like a single time image or something. So bedside brain monitoring is real time, and that's what I love about it. It's important to know that aEEG isn't a replacement for full continuous EEG monitoring. I think that when I first started teaching about aEEG, this was the biggest concern that our neurology colleagues had. It's not considered a diagnostic tool, and it's also not a new tool. So although it may be new to you or new to your unit, it's not a very new tool at all. And it actually was invented in the 1960s by Maynard and Pryor. They were a team of a clinician and an engineer, and they actually created it for an adult population originally, and it was designed to help look at level of consciousness during surgery. But in the 1980s, the Europeans began looking at it as a tool to monitor neonates after birth asphyxia. In the early 2000s, the use really increased in the US, especially with the combination of aEEG with the CoolCap device. And so we saw a big resurgence of popularity, and specifically we saw the use of the CFM. That was actually a qualifying part of the CoolCap eligibility to be in that study. And so we have really now 3 types of monitors that are available. So again, one of the first decisions is what device do you want to buy for your unit? And so we have standalone devices, and now the kind of the only standalone that's currently being sold is the OBM. Then we have also full EEG devices that have the ability to run aEEG modules on top of them, because remember, aEEG is transformed from raw EEG data. And so when we're looking at that, all we need is just the EEG signal collected. And so you can run full EEGs and have your aEEG algorithm showing right on top and easy for the bedside to use, but your neurologists get all of the bells and whistles that they want. And then there are multimodal devices, and there are several of these actually on the market now, and these take not only the amplifier for your EEG and transform it into your aEEG, but they can also display, not necessarily monitor, although some do, they can display other parameters. So they maybe have your heart rate monitor and your aEEG all together. This particular device here is the Moberg, and it actually takes in data from many devices, so from your physiologic data, from your NIRS, and all of that from your cooling blanket and your EEG, and puts it all together in one place. These are great for research, but having a kind of a pickup for clinical use as well. So when we use aEEG, what are the things that we want to know? Well, first off, we want to know the neurological status of our baby. We want to know if there's injury and how severe that injury may be based on the suppression, the level of suppression of our tracing. We want to know if the baby's having seizures, and we also want to know if the baby is improving. So whether that means they're responding to treatment, so if we're giving anti-epileptics, or whether or not we're seeing normalization of pattern. So for example, for a baby who's undergoing cooling, do we see improvement in their tracing? And I did a full other webinar on how to read aEEG, so I'm not going to spend too much time in this particular talk going over how to read the patterns, although I'll show a couple. So dividing up the roles. So this is meant to be funny, so I hope you find it funny. So I think sometimes when we think about, dividing up who's going to do what, it's a little bit like who's going to get the short stick to do what. But there's really three main areas for the roles that we're going to talk about today. Obviously, there are many more, but for just the scope of time, we're going to talk about developing some protocols, who's going to do application, and then a little bit about documentation. If there's time at the end and we want to have conversation, we can talk about maybe the role of IT and archiving and some of those pieces that come up. But just to get your program started really from the ground up, I think these three pieces, if you can address these, which there's a lot of detail even to these, I think you'll be really on your way. So, for another presentation, once I made this little screenshot here that I put in here, and feel free to take a screenshot of it if you want, or email me, and I'm happy to just email this little worksheet to you. But really, if you think about all of the different things, and we're going to talk about all of these things that are in the left-hand column, and if you think about all of your available resources in the unit, there's a lot of things to take into consideration when you're putting together the program. And so, not to, burden one group more than the other, I think a tool like this can be helpful so that you can kind of divide things out. So let's start with then some of the protocol pieces. So developing your protocol, so the who to monitor and when to monitor. And so when we talk about aEEG, and especially in any of the other lectures I've done, I talk about, the really long laundry list of potential babies. And so depending on what kind of unit you work in, you may or may not have all of these types of babies in your unit. So certainly HIE and cooling, those babies, mild babies definitely should be monitored, even if you are not a cooling center that does mild babies. Many places are doing mild babies, but that's another discussion. Anytime, of course, you're cooling any baby that's at risk for seizures, stroke babies, abstinence babies, metabolic syndromes, heart, ECMO, any kid. I actually monitored a kid once, post-arrest, just to kind of see how their brain looked. And it wasn't something that, it was, a kid who was resuscitated okay, but we were a little concerned. And so it was one of those things where, it was nice to just kind of pop that on and have a little look. Of course, for preterm babies, that's a whole nother population. And we look for different things with them, especially if they have high-grade IVH, if they're having post-hemorrhagic hydrocephalus. We know those babies are very at risk for subclinical seizures, especially with meningitis and sepsis. But of course, you can use it for spot checking, for maturation, and even impact of some developmental interventions. So this laundry list can be pretty overwhelming, but this is to say that there's not really any excuse not to be using your device on any specific day. It's just a matter of developing the culture to do so. So I think one of the biggest problems that we see with aEEG is that people don't use it often enough. And it's important, I think, to not just think of it as a cooling tool, but to think of it as really a day-to-day tool that can be useful for a variety of patients. And there really are a ton of data always evolving around the different populations and publications around that use. So I think it's important to use it frequently, or your staff will not get enough exposure. It's a perishable skill. It always seems so easy when we're reviewing the tracings, but when it gets really down to it, if we don't use it enough, people will forget. You won't ingrain it into just the daily practice of your unit. So at Stanford, where I do some consulting, when we started our neuro NICU, we decided we needed to create a top 10 list, and now it's, I think, a top 14 list. And this was a version that I borrowed from Dr. Carissa Van Meers, and it was a top 12 list. And so you can see here what we did was created a little list of our top 12 at the time of patients that we wanted to be sure that they got monitoring. And then we talked about how long we thought the monitoring should be and the type of monitoring and whether or not we needed a neurology consult right away. So some of these patients, so like seizures, we do aEEG, but we always get continuous video EEG as well. So that just means that we may start aEEG if our tech is a couple hours out, and then we'll continue with that, with the continuous EEG once we can get it. And then once we do, we are able to hold our aEEG algorithm on top of our video EEG. So, you know, this is just something that we came up with. It's worked in other hospitals as well. So I think it's, you can look at your population and then you can kind of decide. We actually tracked our population for about a month before we kind of made our recommendations. All right, so now if we know who we're going to apply it to, we made some sort of decisions around that, then we need to think about when to apply, where to apply, how to apply. So I think one of, again, the short stick situations that come up is who will place the sensors. And I would say that 99% of the time, this is a task that is assigned and taught to bedside nurses or advanced practice nurses, the fellows who are in the unit all the time. When to place the sensors. To me, if you have a baby who's at risk for brain injury, at risk for seizures, putting on the aEEG is just like putting on a heart rate monitor for a baby upon admission. So it's as quickly as possible. And again, based on just your resources in your hospital, you need to decide how quick that is. And it could be something that you could potentially monitor as a quality indicator as your program is developing. But certainly time is brain. And if you're concerned, it's important to get this going as quickly as possible. Then the big question is where to place the sensors. And so I'll go through a little bit of electrode kind of use. And so we'll talk a little bit about this. So when we're talking about EEG, we use a lot of terminology that we borrow from the EEG world. And the first one is montage. And really this is just a way to basically say where the electrodes are on the patient's head. And with that, we just say, you know, where are we putting them on the head, and then how do they connect then to the amplifier? And every time we have two active electrodes, and sometimes they need a ground and sometimes they need a reference to be a complete circuit, but anytime we see a pair or two electrodes, that's considered one channel. And so when we think about our full EEGs, they put on a whole lot of electrodes, and it's a multi-channel EEG. When we talk about aEEG, we're talking about a smaller subset of those electrodes. So one of the systems that we use for common language is called the 1020 system. It's an international system of naming the locations on a baby's head. And for EEG placement, you have different letters that correspond to different anatomical parts of the baby's head or cerebrum. And then also we have left and right. So you may see F for frontal, C for central, P for parietal. And then you have odd numbers are always referring to electrodes that are on the left side of the head. And then you have even number electrodes that are on the right side of the head. So when people are talking about the sensors, you may hear someone say C3, C4, and those are just referring to those specific locations. So how do we choose our locations? We use a tool, and Natus really did come out, actually BrainZ came out with, and then after Natus acquired, they still circulate these little measuring tapes. And these really are the easiest things to use for people like us who are not EEG techs and who don't really know how to put on electrodes, but it's a simple measuring tool, and they come in two sizes, a 3.5 centimeter or a 2.5 centimeter size. And that's for a big head and a small head, because the 10-20 system is really based off of a 10%, 20% head circumference system, where the distance between electrodes are either 10% or 20% of the head circumference. But to make it easy, they made a decision to make 25 centimeter being a preemie head and 35 centimeter being a term baby head. And so that's how they came up with the width of these measuring tapes. And so we don't have to measure the head circumference or do any of that. We just use the term tool or the preterm tool, and it gets us in a close enough estimation. So the position of the electrodes are central and parietal, and we'll talk a little bit about why those locations were selected. And so again, we use the measuring tape and we place it over the baby's ears and up the baby's head, and then this arrow helps us determine each location for the central or the anterior electrode, and P, the parietal or posterior electrode. And so I'll show you just a really quick step-by-step on that. So in the end, instead of using all of the electrodes, we just use central and parietal. And as I mentioned, there are some specific reasons why those were the areas that were chosen initially. And so those are some of the legacy decisions that were made in the 80s and 90s when Lena Hellstrom-Westis, Linda DeVries, Mona Todt, when they first started using aEEG in Sweden and the Netherlands, these were the places they selected. And so that's where most of the literature comes from. And that's why we use these locations most frequently. There are pros and cons of using other locations, but if you want to keep yourself established kind of in the history of aEEG, in the classic use, these are the locations that you'll choose. So let's talk a little bit about why these locations are important. Well, I think the first thing to think about and to remember is that baby brain development goes from the back of the head to the front of the head. So if we're looking for the more mature parts of the head and neuronal activity, then the further back we go, the better. The more frontal we are, we're going to not have as much activity, especially when we're talking about preterm babies. And so we don't want to interfere with that. And if you remember back when I showed you the slide of which babies they first started monitoring, they started first monitoring asphyxiated babies. And so from autopsies, we knew, and maybe even early on didn't fully understand, why there were these very specific zones of injury. Now we know that these are the vascular border zones, that these are that watershed area of the brain. And so these areas were most at risk for injury, especially surface injury, cortical injury, when babies had HIE. And so when they wanted to monitor, they decided we should monitor over this parietal area because that parasagittal injury kind of topography would give us a good look at what babies have been injured and which haven't. And so honestly, just from that, they chose those areas. There are some other benefits of that. And if you see up here on the left where you see this big temporalis muscle, well, if we were to monitor too far low, we would get a lot of temporalis interference. And so when we apply our electrodes, we do so very high on the head to avoid the interference and artifact from the temporalis. If you're using hydrogels, this is a little bit easier to do. If you're using needles, you need to just be mindful of this muscle and how far up it comes, and start your insertion point higher so that your needle doesn't transect into this area and get a lot more electrical artifact. So that's always something really important to remember. I don't have a muscular picture of the frontal lobe, but one of the risks of putting aEEG leads on the frontal, not only because of the lack of maturity, but because there's so much muscle artifact from the face, babies crying, grimacing, all of that, you pick up on this all the time. Also, when babies are sucking, you know, on the pacifier, if you have any electrode in this temporalis area, you're going to definitely pick up that artifact, and it can be quite rhythmic at times and really fake you out for seizures. So location is really important. The third or fourth or fifth reason why we choose the locations is really for yield over seizures. And if we look overall where those seizures come from, we can see that Renee Shellhouse paper from 2007 really demonstrated that that central area was really, you know, the place that most neonatal seizures migrated through. Some in the temporal you can see from this article, but still a pretty good yield even in this 2003 paper. And seeing that the frontal lobe has a lot less, and then the parietal is not mentioned in her paper because the parietal is not a standard channel for the neonatal montage. So you have to intentionally place that extra lead if you want to pick them up specifically over the parietal. And when we do our full EEGs, I always recommend that our techs put on that extra parietal channel for us. But you can see that the central is a really high yield, and so if you're only putting on a couple electrodes, then you want to be in that spot where you can definitely pick up those electrodes. And most neonatal seizures, even if they originate in another place, tend to generalize through that central zone as well. So if we put electrodes on, another important decision is to make a decision on how long you'll monitor and when to remove them. I mean, I've seen electrodes on babies for, you know, 5, 6, 7 days, 8 days, 10 days, and people are like, well, I don't know, no one wrote the order to DC this. So it is important to think about, you know, how it's adding value to the patient. It is extra work and maintenance for the bedside nurse. So knowing that you have a protocol in place of when to monitor and for how long, maybe you want to monitor 24 hours after you finish rewarming, and your EEG department wants to pull the device right at rewarming. So you have to have a decision. So then we need to switch over to our unit-based device. Or maybe we want to continue until the baby goes to MRI. So, you know, those are just all decisions that you can make in your unit. So regardless of what kind of sensor you use, and there are many sensor options on the market, from, you know, cups and discs that our neurology colleagues use to needles and peel and stick hydrogels, it's really the same, you know, steps that we go through each time. We choose the site, so using the measuring tape. We then cleanse the skin or prepare the skin if we're going to do hydrogel. Then we apply or insert the sensors, look for our impedance, making sure it's quality. And quality impedance means less than 10 kiloohms, and then secure your sensors so that they don't fall off. And so here's just a quick little picture of those steps, and using the measuring tape, and this is on a small baby, so we're using the preemie size. And we use a toothbrush often for parting the hair and creating good exposure to the scalp. You want to mark those spots with a pen, surgical water-based pen, skin marker, and then you want to have a really clean runway for either applying those hydrogels or for applying your needle. If you're using hydrogel, you do have to scrub the skin, and then you have to cleanse the new prep gel off and then apply them, and again, look at your impedance here. So we do always want our impedance to be under 10. That gives us a good quality tracing. All right. So, so for those of you who are just joining, if you want to text in to join our poll, I just wanted to get a little sense from you. If you're already using aEEG or you've had these discussions, who's applying aEEG in your units? And so we're getting a couple bedside nurses. Yeah, it's probably one of the most popular that I see. And it's the 100% answer this time. I'll give you guys a couple minutes who joined in later if you want to type in the neuro NICU and then just do the 747-444-3548. And you can tell us. But this is super common. Bedside nurses, and so if you're doing needles, it's one thing because that's not a super time intensive procedure. But if you're doing hydrogel, it is important to know that it can take people 30 minutes, 40 minutes, even if they're skilled, to get the hydrogels on well. And so planning for that in your team and knowing who's going to do that. Is it the bedside nurse who's taking care of the baby and everything else? Well, they may not have time to get to that sensor application for hours. And so making sure you've got full resources available so that you can get to that is really, really critical. And sensor application is the Achilles heel for this, and I say that all the time. All right, so let's talk a little then about how to read aEEG. And I mentioned earlier that I did that previous webinar on the 7 steps and the 7-step method of reviewing aEEG. But just to make sure that you know, I'm giving you a little bit on that today. And really focusing more on not so much how to read, but who will read. So who's going to look at who's going to look at the tracings, making sure that you have good, stable quality? Who's going to interpret the tracings? So looking at the tracings and kind of trending them, I think that's the bedside nurse's job. But interpretation and decision making, that runs to the medical team. And how often will these different people be looking at aEEG? So we've done some quality stuff at Stanford in the last couple, probably the last 6 months for our seizure babies, where we have created a requirement for our medical team to come to the bedside at least every 3 hours and look at the tracing. Yes, the bedside nurse is continuously assessing, you know, as she's doing her things or he's doing their things at the bedside, but it's not enough. We want extra eyes, and so that's a really you know, important thing that we've added to our kind of management. So when we think about recognition and teaching recognition, we want to be sure that we are thinking about what are the most important, the key things that we want to be looking at. And so we've got pattern recognition, where we focus mostly on the normals, or what I like to say, the expected patterns for age. We also want to make sure everyone is aware of what suspicious patterns are, so that those are taken care of in a you know, rapid fashion. And then we want to focus on symmetry if you have more than one channel, which most of our devices do now. And then you want to think about your criteria for notification. So who will you notify? So if you're the bedside nurse and you're taking care of a baby and you notice that there's increasing impedance, do you have a team leader or a super user who will come and fix that for you? Do you need to know how to do that yourself? Is that part of your skill set that's assigned to you? And then the other piece of notification is really changes from baseline. So whether this is a bedside nurse noticing kind of a change in the background pattern, or maybe a suspicious area that they think might be seizures, or maybe that's you as the medical provider for that baby overnight needing to notify neurology that you think you see something that looks suspicious. So creating a criteria for notification is important, because, you know, again, it's a tool at the bedside, but if the information only stays there at the bedside and there's no communication, it doesn't really serve us very well. So let's talk then about kind of the basics around interpretation of aEEG. And so probably all of you are familiar with the markings that are on an aEEG, but just in case, it has the left margin On the y-axis, we have our 0, 5, 10, and 100 microvolts. This is standard aEEG paper. Your monitor may have different widths, but it's always the same it's always the same semi-logarithmic scale. So where 0 to 10 is linear and 10 to 100 is logarithmic. And so it's easy for us to be able to say this baby's at a 4 versus baby's at an 8, but a little more difficult when we get in the logarithmic area to say, oh, the baby's, you know, is this a 40 or is this a 25? And some devices do have like a 25 mark, a 50 mark, which definitely helps. Along the x-axis here, we have breaks of 10 minutes. And just as a reminder, it takes 15 seconds to create one line of aEEG. So we stack up 40 lines, and that makes about 10 minutes. So again, 15-second integration makes one pen stroke. Then to interpret, all we do is kind of look at the thickest part of the upper margin and the lower margin, and we look for the trend over time. And for a healthy, normal term aEEG, we want that upper margin to be greater than 10, and we want our lower margin to be greater than 5, except for when the baby's having a discontinuous trace for sleeping. So we see here a change between a continuous normal trace, a dip down during a sleep cycle, and then a drifting back up, and then a drifting back down. And then we consider this a normal sleep-wake pattern, you know, on top of a continuous background. So that's a great, beautiful, healthy signal. We sometimes have premature babies or babies who have injury, and so we see different patterns. But again, we have the same marks, 10 minutes between the gray lines, and we have the same scale on the left. Some monitors display the EEG right along with the aEEG. Some you have to switch screens to see the EEG, but it should always be available for you. And in this case here, we have the upper margin, which is above 10, but a lower margin that is below 5. So for a term baby, not what we would expect. For a preterm baby, certainly within expected range. And then we can sometimes have extremely pathological looking patterns where this is an example of burst suppression, where we have a very suppressed lower margin, and we have occasional bursting that's happening. And we know it's a burst because it reaches over 25 microvolts. That's the definition of a burst. And they can come at different intervals, and depending on how frequently they are occurring, the density of your burst suppression pattern may change. If you look on the EEG, you'll notice a pretty suppressed pattern, interfered or interrupted by a rather large burst, and then you go back to a low voltage suppressed tracing. And this one in particular has some artifacts, some heart rate artifacts as well. Pattern recognition and notification. So we talked about these different patterns, the normal versus abnormal, suspicious patterns, and then of course our criteria for notification. One of the most important ones to recognize is the seizures. And so I wanted to show this example. One second, my neighbor gardener just got here. One sec. So sorry about that. Okay, so this is a seizure pattern. So you can see that we have a discontinuous pattern that is interrupted by this very massive uprising that lasts for about 10 minutes. And if we look at the corresponding EEG, we see this very rhythmic spike wave, spike wave, spike wave pattern that definitely fills this whole 10-second EEG spread up above, and is certainly worrisome and should be reported to someone. Let's see here. All right, so if you have your phone out and you're participating in the polls, I just wanted to know, what are some of your biggest challenges about interpreting? So like I said, it always looks so easy when we are, sitting, in classes like this and, looking at patterns in books. It always seems so easy, but what's really the challenge that some of you are facing? I know while I'm waiting for some of you to respond, you can chat in if it's easier too. There's a chat little thing on the menu there. Some of the things people say are, they feel very unsure. They don't have confidence. They're medical legal, they're worried. So those are other concerns. Some of the challenges are artifact, right? We see a lot of artifacts. So what are some of your other challenges that maybe you have? Or if those are maybe probably the most common ones that people experience. Oh, someone's chatting in, so let me grab that. Consistency. Yeah, so consistency between people or consistency in the baby's pattern? You could also unmute yourself if that's easier. And I think this is an interesting one to think about between people. So one person thinks it's one thing and one person thinks it's another. Yeah. So I think this is an important thing to talk about, because, and I think this is why ongoing education with your team is really important. Yeah, pattern identification between providers, absolutely, and charting. Yeah, no, I think that's a really, really important. No, those are good. Yeah, I think that's a real challenge. In some units where I've been, we've done some QI things where we had neurology participate. They were very interested in the aEEG tool and wanted to make sure people did feel confident. And so we did a little quality kind of teaching stuff for a few months, I think, before we started actually documenting in the record. And so people would go by the bedside, they would review, and then at a specific time, we would have the neurology team and the neuro-NICU team do some rounding and look at the aEEG patterns together, and develop some consensus and discussion around maybe why there was differences, and helping people gain that confidence. And that confidence is really, really helpful, and made people feel like they didn't have to, put their name, in the chart about it to start with, but that they definitely, until they really had to kind of like name it at the bedside, their feet were to the fire to choose a pattern. It was easy to just agree, but until they had to really hold it as their own, it didn't quite sink in quite the same way. So education, super important. And again, I think it's that perishable skill, right? So if you've been doing it every day, it makes it pretty easy. If someone's just joining your team, it's new for them, they don't have as much experience. It's pattern recognition. You have to see the patterns frequently before it starts to make sense. So great. Yeah, those are all great answers. All right, so let's just wrap it up about how to document and what to document and where to document. Again, this dividing up the roles. So what will the nurse document? Who will do, what will they say? What will the medical team say? What will the neurology team say, if anything at all? And where will this information live? Will you take a snapshot? Will you not take a snapshot? Will you save the file? Will you not save the file? These are all, again, going back to the very beginning of your protocols, these are all decisions that you make to start, and that you may change your decision as time goes by. But definitely thinking about all those different roles and who will document what, and to what degree and to what specificity. So I think that it's important to know that each device does have a way to event mark. You can either create a list of high priority events, you can create a custom pick list. I think that makes it the easiest for bedside providers. And then especially if you're gonna ask the nursing staff to event mark, then if you are reviewing the tracing, if that's your role, then you need to utilize those event markings, and they provide an enormous amount of value. but only if we look at them. And so we definitely want to look at those event lists and use them in our interpretation. So for things on the device that you might want to consider, definitely anytime medications are given, that could affect the background pattern or seizures. Anytime that we see clinical observations of seizures, we know many of our baby seizures are subclinical, so we don't always see them, but certainly if there's ever a clinical correlate that can be noted, that's really helpful. Hands-on care as much as possible when people can note this, especially feeding times. Movement artifact is a little bit easier to pick up, but padding and burping certainly are really a challenge. And sometimes just change in ventilation or vital signs, those are helpful to note as well. But again, it's redundant charting. None of this goes into the EMR. So I just wanted to show a couple examples of when medications are given. This is a drastic one where the baby was given a dose of morphine and midazolam. This is an old tracing from the early 2000s. And you can see just this rapid change in the background pattern that was noted here. This is an example of padding. And this is certainly something that fakes us out a lot. And it's important to really educate nurses in documenting this. If you are using a standalone aEEG device without a video, then you can be faked out by padding all the time. And so this is just to share that example and to just let you know what it looks like. It's very fast. Most seizures are not this rapid, but you can kind of imagine someone kind of padding. I'll try to clap loud enough so you can hear it, like, padding the baby. It's very rapid, and seizures are typically not that rapid. And so this is a big fake out that we get a lot. You can create cascades in the EMR. So nurses might document if the monitor is in use. They might say what type of monitor, the level of impedance, the microvolt levels. Those are all things that the nurses can assess the margins. They're not interpreting the pattern per se, but they're certainly telling where the voltage is. And just like every other vital sign, they can report on those kinds of things. They can comment to the presence of cycling if they have been taught to do that. And those are all just kind of basic things that you can add. To wrap it up, I just want to talk about what are some ways that we can improve our programs. So you start a program, you get it going, but is it the best that it could be? And I think it's important to always think about opportunities for quality improvement. So all of the devices have a way to look at the impedance level. So how are you guys doing with your impedance? Is there room for improvement? Could you do better? How often is it stable? We did a poster presentation 3 or 4 years ago at the Florida International Conference, where we showed that we could teach more than 50 nurses how to put on aEEG leads, and that we could have clinically stable impedance levels. Maybe one of your quality indicators is how quick you get your aEEG monitor on. So thinking about that time to application after admission. So are you tracking that? Could you do better? How about the timing of review and reporting? How's that going? Do you have a way of looking at who's been reading it? Do people document on the tracing when they've done a review? Our neurology colleagues do. Maybe we should do that too. Are we doing reporting? How often is it getting in the record? Depending on what your protocol is, just looking and seeing if there's variance. And then maybe you could track your utilization of neuroconsults, how many video EEGs you're getting, what are the length of the video studies. I mean, there are all sorts of ways to look at your program and to then think about whether or not it's really the best that you can be. So I'll wrap up there and just say, are you ready to jump in? I used to always say this when I would go and do aEEG trainings. It's, doing aEEG is opening a can of worms. It's a big job. And so sometimes we look in and we're like, I don't know, this can of worms is too much for me right now. But certainly if you take a systematic approach, break down the tasks, it's definitely something that is doable. And I would invite you to jump in. It is a tool that is really valuable, gives a lot of bedside knowledge and information that we just can't get any other way by us at the bedside to own that information. And it's really that real-time tool. So again, I'll just say thanks to Natus for supporting the production of this webinar, and make sure that everyone is aware of our upcoming Neuro-NICU nurse training course in San Diego that's happening in February. So we have a few minutes before the top of the hour, so if people are still wanting to hang on or have questions, I would love to answer any questions that you have. Of course, you can always email me if you have questions, and do that. So Janet, you just raised your hand. Does that mean you have a question? And if so, you can just unmute yourself. Or maybe I can unmute you. Can you talk now, Janet?
Can you hear me?
Yeah.
I was just wondering what the average cost is to start up a program in a medium-sized NICU.
The cost to set up a program, just aEEG?
Yeah.
So the things that I think you need to consider are going to be equipment, obviously. And so you're looking, depending on if you're just getting one, standalone device, you're talking maybe 20,000. If you're talking about integrated, multimodal, full video EEGs, 40 to 60,000. So depending on kind of equipment. Then I think the pieces that people probably don't think about the most are the training time. So who are you going to train? And how many classes and the training time for that. I think that's one of the more important pieces. The disposables are not too crazy, but probably a few thousand a year. Just thinking about like sensors and really depends a lot on usage. How many cases you're going to do a week or a month or a year. The sensors range anywhere, I think, from $5 per set US to up to $50, $100 per set if they're going to be reusables, and even some disposables. So if you're going to do 100 cases, then you multiply that out. But I think the training costs are probably the biggest kind of thing that people don't take into consideration for the budget, and then the device itself. But other than that, there's probably not a lot of other costs.
So how many aEEG machines would you recommend for a 30-bed unit?
I think in an ideal world, and again, I do not work for any device company, so let me just say that. I think probably ideally, I think one for every 10 beds, like for a busy NICU. But what we did at Stanford when we first started up is we honestly tracked our babies. So we went through and we printed out a census every Monday. I think it was for 4 or 6 weeks. And what we did is we went through the unit and we did 2 things. If we had all of the devices that we'd ordered and if we had our neuro-NICU running, would we admit this baby to the neuro-NICU today, and would he be on a monitor? And so when we went through our unit census, that way we could see, of all the babies we had, if we could have, would we have monitored? If we could have, would we have admitted to the neuro-NICU that day? And it helped us. We realized it was about 1/3 of our patients that we would have admitted to the neuro-NICU. And then, about at least half of those we would have monitored. So then it helped us be able to gauge, kind of the scope of our program. And then it also helped us gauge how many devices we needed to buy. I'm assuming Shannon, that's Shannon Tinkler. I think we've got, I'm trying to think of how many aEEG devices we have now at Stanford, and I think we have 8, and we have 3 full video EEGs dedicated just to the neuro-NICU, and that's a 50-bed, let's say, unit.
So we have 7 standalone aEEGs, 3 multimodal, and then I think 11 or 12 mirrors.
Mirrors and stuff. Yeah.
Mm-hmm. And then the NKs.
Yep. Thank you, Carlos, for joining. I just texted. Yeah, no, it's a great question, Janet. that help, I hope?
Yeah, it does. Also, I don't want to monopolize all your time, but
Yeah, it's fine.
for your abstinence babies, do you admit them to the neuro NICU?
Not specifically. So at Stanford, they're not on our list. We've had some babies, cooling babies, who were also NAS babies. And those babies have, by nature of the cooling and HIE, been in our neuro NICU, but specifically to do them to our neuro NICU, they're not on our top 12. The population there is different than other places. We don't get a lot of it there.
Okay.
But certainly places like Madison, they're actually running a randomized control trial. They're doing on NAS babies. There are a couple places in, oh, I'm blanking, Miami Valley, Ohio, Dayton, Ohio, I think. And they're doing NAS babies as part of their neuro NICU, and they're doing aEEG monitor routinely on them. So Madison, and those are two places I know of that are looking at them. But certainly if they're a population that you see, there is developing evidence for, you know, their background patterns, and certainly they have neuro risk, and they're at risk for seizures, they're at risk for other background dysfunction. They tend to have very irritable aEEGs, and they lack sleep-wake cycling, which is not surprising. But I think it's a tool that could help guide even treatment to some degree from a sleep-wake point of view.
Thank you.
Mm-hmm. I like that you raised your little hand, little icon, like hand.
Didn't find out how to turn the audio on, so after I did it.
No, that's okay. That's all right. Any other questions? You can definitely chat them in, or. And thanks, Shannon, for being here.
Yeah, sorry I was late. I was fixing the EEG.
All right. Well, if there are no other questions, we'll wrap off for the day. And thanks, everybody, for joining. And the recording will be up, and feel free to share it. And as always, great to be with you. So talk to you all later.
Bye.
I'll do my little video and wave. Goodbye.